tomorrow, it's not, you're not looking at visit 1 for
Okay.
patients and that's it.
Okay.
Like that's where you were getting confused.
Okay.
You know, like IMV2, you're not looking at just visit 2 of patient. This is just what monitoring visit it is.
CRA is IMV visit 1.
And that's what tomorrow's gonna be.
Okay.
Yeah.
Okay.
We
So
did
we're
like
looking
a
at
pre-IMV1 with a student last week,
Okay.
but it wasn't official.
Okay.
And your guys are an official visit. With
That's
her, it
good.
was just like a practice.
Okay.
So if we're doing the IMV1, we're doing everything up until the
Everything.
day we get there.
Yeah. Me and the student last week already reviewed a lot of what you're gonna review.
Okay.
So I have the answers.
So
Okay.
what
I'm
have
not
you
gonna-
reviewed? You've done the screening, visit, and all that.
Yeah, but since we've left, there's already new visits.
Okay.
So
So all
you
the
start from the
visits that
beginning.
happen.
So we go back and start from like screening visit,
Yeah.
whatever the other visits.
Yeah.
They,
like
Nothing's been monitored.
IMV1 can happen at week 4. So if there were like 4 visits
Yes.
between that, we would have to do all those visits up until.
Yeah.
Yes.
Monitors go every 6 to 8 weeks.
Okay.
Okay, so IMV2 officially will be 6 to 8 weeks from now.
Correct.
Okay, but if students come in between, we take them, but it's not an official. You guys are on an official one.
Okay.
Okay.
Like the next one, 6 to 8 weeks is IMV2. I don't know
Okay.
who's gonna be here, and if nobody's here, I have to go.
Okay.
Alright, so the show goes on.
Okay.
Alright, so this is where, don't get confused, just because it's monitoring visit 1, you're not just reviewing visit 1
Okay.
of the patient stuff. You're reviewing everything,
Everything.
all the source data, okay, all that stuff.
Let me be sure of this, but I think it's probably the same thing. Now, it seems to have helped us anyway. Is schedule of assessment.
Yes, that's the
Yeah.
cheat sheet.
Okay. Okay.
Hey, you guys had
At
a
least
real
we know.
cheat sheet.
At least we know
Yeah,
what to
right,
do.
yes.
Schedule of assessment. So if you don't know the protocol, like
Yeah.
you guys today,
Yeah.
okay, that will show you at least what
Kinda
needs to
guide.
be on the
On
each visit.
Okay.
Okay.
It's not gonna tell you inclusion exclusion criteria. You have to know those things,
Okay.
like
Okay.
prohibited meds.
Mhm.
All right, those things are not gonna be in here.
Okay.
All it's gonna say on visit 1,
You're supposed to do
it's
this.
gonna say IE. One of the many things will be IE criteria.
Okay.
Physical, ICF, you know, and then
Okay.
visit 2, same thing because visit 2 is randomized. So IE criteria again. So you know that it needs to be done, okay, but you won't know that it's done correctly or not unless you know the protocol.
Okay. All right.
But you at least know
She's gonna
what's
take
missing.
over.
She's what?
She's gonna be the designated healer.
The protocol reader.
Yeah, I can do that.
You're gonna read the one
Hey.
too.
For
No,
cancer,
we're
you
all
should
gonna get it tonight.
Yeah.
We're all gonna
I'm
get
emailing it
tonight.
tonight. I'm emailing
She's the
it tonight.
designated. She's number 1. How we
Yeah.
started.
But seriously, read it because you're gonna, and then you're gonna want to Google all the things you don't know.
Listen. Okay.
And get the RESIST. I will email you the RESIST criteria too,
Okay.
because that's stuff I'm still learning myself.
Okay.
Alright? So yeah, schedule of assessments will teach you, will show you visit 1, visit 2, visit 3, you know, what needs to be done. And so you'll know when you're looking at the source. And then Monica had you look at a source, right?
Yes.
To make sure it was done
Yes.
properly.
Yeah.
Was that good?
Yeah.
Yeah, that actually helped us. Those little like exponents up there
Mm-hmm.
helped out a lot.
Okay. So what did you discover on this thing?
Okay. You want to start or do you want to start?
Well, on our source data review, we saw that some of the labeling wasn't there. The height wasn't there for the vital signs.
It wasn't.
Wasn't. Mm-mm.
I was missing.
It was missing. Mhm.
Yes.
And then also the, what was it?
Temperature.
The what?
The temperature.
The temperature
There
needs to
should
be oral.
Oral temperature, but it was not there.
Oh, for the physical?
Yes.
Okay, for the vitals?
Right. Yes.
And then
Yes.
one of them, I don't know if it's for all of them, we only got through 4, but one of them didn't have when seated to measure the blood pressure It
Yeah.
didn't have that statement up there where the other ones did.
The other ones did.
Yeah.
It was surprising that one form will not just be missing that.
Yes.
Mm-hmm.
So what do you do in those cases, okay? If you notice that on one patient,
Okay,
Mm-hmm.
what you do, you should look at the same thing for all the other ones, okay?
okay,
Okay.
Because that's more of a risk-based approach, right? So like, basically risk-based monitoring, you'll review like 20% of a subject,
Mm-hmm.
okay,
and you'll see, or you'll review an entire subject binder. There's different ways to do risk-based monitoring, but one way, you review one patient binder,
Mm-hmm.
everything, and all these places you find mistakes, like you just did. Okay, physical, the temperature's missing, what
height,
else?
height seems to be missing in all of them.
And then not seated one, blood pressure. Okay, now you're starting to notice things.
Good
So
trend.
now, more than likely, these are missing on another patient's too,
Yes.
because it's the same site. They did it for some reason, it's something with their process is wrong.
Okay.
So now you just found, without even looking, you probably found the mistake a bunch of times, right? And then you go to confirm.
Okay.
And if some of them are not missing it, then that's okay. You know that these are okay. But then I guarantee you, if you look, the others subject will have the same issues. So that's
Out of the 4, only one, right? No, actually, all of
because
them.
there's like
All-
8
all
subjects, right?
It was all of them,
Yeah.
all 4,
For
right?
height thing.
For the height.
Height
all of
was
them.
missing in all 4.
All-
But there's 8 subjects, or how many?
We were able to get to 4, that's what I'm saying.
Yeah, but how many are there?
8.
So chances are, if you look through the other 4,
Probably
that maybe this is also happened there.
missing. Okay, that's what you're saying.
Yeah. Yeah, so that's good. You're figuring out. Ideally, you're gonna have time to look through every patient, but risk-based monitoring, that's one way to do risk-based monitoring.
Yes.
So, if you see that, what do you do with vis-a-vis talking to the CRC, the clinical coordinator? You just make a note to the side. At the end of your visit, do you just put it in your report, or do you call the?
Oh, you put everything in your report.
Okay,
Everything.
okay,
Okay, you let the sponsor know everything, even the most, what you think is the mundane
thing,
issue. Let them tell you not to be so detailed.
detail.
Okay.
Alright, and then, so for your next visit, then you'll know, okay, they don't want me to be this detailed, they want a summary of
Okay,
some of, like in my reports, they say don't list every single issue, give us a summary of some of the most important things. But for the follow-up letter, you wanna put everything.
Okay.
So still, you gotta be detailed.
Yeah.
And this is why CRAs use sticky notes.
okay,
Yes.
Okay, so they'll put it where you don't have to, nothing in GCP says a CRA needs to use sticky notes.
okay,
But that's why they do it. If it's something simple like a header is missing,
okay.
okay, like instead of putting that in your report, you can put CRA discovered numerous headers were missing. Instead of listing each visit, which page, you can say numerous headers were missing.
In your report.
Yeah, CRA talked to CRC,
Okay.
CRA discussed with CRC, and CRC was able to rectify during visit.
Okay.
So that takes care of it, but the sponsors read your report, they're gonna know that you're on top of it,
Okay.
instead of not writing anything, so you wanna write it. And then if it doesn't get fixed at your visit, it goes in your follow-up action items,
Okay.
alright? And that's where the site needs to resolve those action items, ideally before your next visit. And at your next visit, the first thing you wanna do is look at all the previous action items. You don't have to do it in that order, but that's what I do.
Okay.
I look at, okay, what did I leave them to do? Before I start anything else, let me see if they fixed these things. Right, and if they didn't,
Mhm.
that continues onto the next follow-up letter.
Okay.
If they did, then it's closed. That
Okay.
action item's closed.
So a lot of these questions are asking like when it has the protocol been revised since last visit, or you know, what was done since last. So we would look at the report from last visit
Yes,
and then just check to
Yeah,
see
you
if
will
that
know.
was updated.
correct,
Okay.
correct. But tomorrow's your first. Okay, so there is no previous visit. The
So how
previous
will we
visit is
see
the SIV, site initiation visit.
Okay. All right.
So we'd have to find the report for the SIV,
Mm-hmm.
to see which protocol was amended there.
Okay.
So we have to look up for the SIV report.
And that's how we know the most recent protocol amendments and most
Yeah.
recent ICF is from the last.
Yes.
Okay.
But yeah, those are good findings because then you know, okay, these are missing, chances are they're missing it elsewhere. And what do you do if something is repeatedly, let's say they repeatedly don't put the blood pressure while sitting. And so that's something that the protocol says you have to do,
Mm-hmm.
and they don't do it.
Isn't that what they call the CAPA thing?
Yes, CAPA.
Yeah.
Corrective action, preventative
Active
action.
action.
This marker's not working. CAPA. Okay, so that's what you do if it's repeatedly. But the sponsor has to request that, but you can put it in your report.
Okay.
Or you can train the site as well, training. So the CRA is allowed to train the site when they think that it's necessary. If you have time, you can retrain the site on the protocol.
Okay.
If it's apparent to you that they don't understand something, so you can do that.
And that comes under CAPA?
No, CAPA is different. CAPA plan has to come from the sponsor, that the sponsor is requesting a corrective action,
Okay.
preventative action. But you as the CRA can recommend it in your
Okay.
report.
Okay.
And you don't have to put, I recommend a CAPA, you just put, I recommend site to retrain.
Okay.
And then sponsor will read that and require a CAPA plan.
Okay.
If you're working with an inexperienced sponsor and you're a senior CRA, you can put CRA recommends CAPA.
Okay. We didn't see any protocol deviations. We couldn't find
Oh,
any.
okay. A deviation.
So a few
Deviation
assessment
log.
skills were missing.
So we looked at the deviation log and we didn't see any.
Ah, okay.
We didn't see anything in the deviation log for the protocol, but I could have recalled that I would have pulled the book and saw a protocol deviation.
You see?
But
so
I
you
didn't
can't
see-
rely on logs.
Yeah.
I don't know why none of these work. You can't rely on logs to tell you if something was done or not.
Oh, really?
Nope, because who's doing those logs? The same site that's not doing the things.
Right.
You just think they're gonna have it right on the log, just by miracle?
That's true.
They're missing height,
Mm-hmm.
vital, who knows what they're missing. So you can't assume they're gonna not be missing something on deviation log. So if it's blank, it doesn't mean that it's no deviation. You have to actually go through every page and with the protocol.
Protocol.
Yeah, yeah. And then it's your job to say, hey, there's a deviation, this needs to go on the log. You need to submit to the sponsor in the IRB. It's gonna go on your report for sure. If it's repeatedly, you have to retrain them, or the site has to retrain themselves, and that goes in your report.
Okay.
So you have to be very detailed in these reports, because the sponsors now read every single IMV report. It used to be they didn't read any, because they relied on the CROs to do that part. And the FDA in 2016 came out with an amendment to GCP and said that the sponsors have to review every monitoring report.
Oh, wow.
So now they're strict.
So one thing we kind of wanted to make sure that we know where to look for, like stuff like the site address and the subject enrollment, like there was no definite place that says this is the site, the address.
Where do you get that from? Where do you get the site address
I
from?
know we can get it in 1572,
Yeah.
but then we have one address. What's
That
the
was
address?
different.
That was different,
addresses.
and then so.
Because
Where-
the site moves, right? Site
Yeah,
moves.
it had it had an
So
additional site.
will
One
there
of the site
be an
closed.
amended 1572?
Yeah, of course. Of course.
I don't think we have an amended 1572.
I didn't see the amended
That's
1572.
another CRA finding.
Yeah.
That's a big one too.
Mhm.
When does a 1572 get amended? Give me some examples. We told you one already.
If there's a survey changes.
Okay, good. So sub-I change,
Like something like the
PI
finance?
change.
address
Yeah,
change,
Address change.
Yeah.
Additional
Address
site.
Uh-huh.
PI change, which is rare, but it does happen. PI change. Sometimes the PI is busy and one of the sub-Is wants to be a PI, so the sponsor can approve that. But then you need a new form.
I don't know if it matters. If there's any change in terms of financial interest, maybe.
No.
That would be
That would be
financial
financial disclosure.
disclosure.
Financial disclosure form.
Financial disclosure form. Okay.
Yeah. Anyone who's a sub-I.
Sub-I. Okay.
And then 1572, if a sub-I leaves also,
Okay.
okay, they need to be removed.
Okay.
And then what else? If that triggers, this is an interview question, okay?
Okay.
What do you do when you noticed a sub-investigator was removed from the 1572? As a CRA, what do you check? What's the next things that you check?
If it's been removed.
Yeah, if a sub-I is no longer at the site, what do you check?
To see if they replaced them.
If they replace him for one
They
thing.
don't need to.
Do they need to
The
file
delegation
another
of duties.
There you go.
1570
Delegation of
Duty.
duties or DOA, same thing.
amendment? Okay.
Delegation log, okay, and then another 1572. You need to make sure it's updated.
Okay.
And yeah, delegation duties log. What on the delegation log though? What needs to be done if the sub-I leaves?
What, they need to, I guess, take out this sub-I's information or
No, not take out.
take out the duties of
The
the
stop
sub-I.
Stop date. Yeah, end date.
Stop date.
End
Okay,
date. Stop
end
date.
date.
Okay.
Ended.
Yeah. Now you can take out.
Okay.
And it's good we're getting this
Ended.
out of your system.
Yes.
End date. Okay, you can't take it out. Right, so that's why they have a log. Yeah, I'm trying to think what else. Okay, so that's if a sub-I is removed. What do you do if a sub-I is added to
Well,
1572?
Same thing.
Same thing,
Amend
but
they're
change,
gonna do-
amend the
and
start
then
date.
training log.
Right.
Training log. That's the
protocol,
difference, right?
yeah.
Both of these things as
Yeah.
well, except it's going to be a start date now.
Mhm.
Standard.
New 1572,
Two.
new training log,
Log.
and new CV,
CV.
GCP,
FI, FDA.
15. Financial disclosure,
Form.
Mhm.
Medical licenses.
medical
Oh, that's
licenses if
good.
applicable. Yeah. Okay, GCP.
GCP, that's true.
So these are things that happen all the time.
Okay.
Right, so they expect you to know this as a CRA, and they expect you to think automatically. Okay, I see a new sub-I, boom, I know all this needs to be checked. Nobody needs to tell me to do this. I need to do this. This is like automatic. That's what those are the kind of things they ask you in an interview, because they don't want to retrain you on this stuff. You're going to be trained on the
Right.
protocols.
Okay.
Yeah.
Every protocol is different. They don't have time to train you on this
Right.
stuff.
Oh, that's another thing. When every now and again, say like there's a protocol amendment, and you are supposed to retrain the site
Mhm.
on the new protocol. Exactly how do you do the training? Do you do it like a PowerPoint, or do you just have something like this? I have a copy of the protocol in front of me. I give you a copy. I give her a copy. I give her a copy, and then I go to page 1. Okay, this and this, and then we
So,
say what
For SIV, this is usually how it works. For SIV, the sponsor will provide slides,
slide.
training slides.
Okay.
If it's amended, generally they don't give you slides
Okay.
unless it's a good,
Major.
really good sponsor and they make you slides every time it's amended. Usually you'll get a summary of changes for the protocol.
Okay.
Summary of changes, SOC. Okay? And the site gets that too. So you don't have to reread the entire protocol to figure out what's the changes.
Okay.
It will tell you, this is the summary of changes. At visit 1, instead of collecting blood pressure when seated, we only do it when standing. Okay, so it will list it. This is one of the changes. Maybe that's the only change. Maybe there's 5 more.
Okay.
Okay, so then now you know what you need to train the site on. You don't need to read the protocol again
Okay.
unless you think that they don't know it from the first time.
Okay.
Alright, that's retraining. You just go through the summary of changes and you document on the training log.
So
You don't have to train them though.
I don't. Okay.
At the SIV is the only time you have to train them.
So how will you do that training at the SIV? Just in case, you know.
They
you get
give
a
you
job
slides.
and they-
Sponsor give you slides.
Okay, so then you come find a room like this.
Yeah, you bring your laptop
Okay.
and then you go through it and you have them look at it.
Section by section.
Yeah.
Okay.
And then say any questions?
Any
No?
questions?
Okay, then we sign the training log.
Sign the training log that
Yeah.
they've been trained.
For amendment, the sites can train themselves.
Okay.
Okay, but unless the sponsor requests, hey, you need to train them on.
But there will be a
summary.
new training log completed for amendments, right?
Same training log, but new line on it.
New line.
line.
So
Yeah.
that's something we would check when we see an amendment to the protocol.
Automatically. Just like sub-I's or PI or sub-I's change,
Yeah.
it's automatic. These things, no matter the study, there's rules to research. This is why they don't want inexperienced CRAs. Because it's hard enough to train you on a new protocol.
Yeah.
Imagine training you on all this stuff. It took us 3 months in the academy. And that's just scratched the surface.
Yeah.
Right? So they don't want to retrain you on this. They want to assume you have a working knowledge of the fundamentals.
Okay.
They'll train you on the new protocols that they give you. Because that's a lot to learn. You'll see tonight with the oncology protocol. That's a lot to learn. I don't know if we have slides for that one. For the study tomorrow.
Oh,
Okay.
yes,
Have
but
to
that'll be
look.
better.
And
Yeah, very better with slides.
I could ask.
Okay.
Slides are easier. I know for the other study we had with them, cancer, we had a slide. For this one, I don't think we do.
Oh, okay.
Okay.
Okay, what else?
So if there are multiple versions of ICF in patient's folder, they should all be present in the folder like 1, 2, 3 or only the current one?
If they all occurred when that patient was in the study, they all need to be in there.
Okay.
Okay, but not every patient's gonna sign all the forms.
Okay.
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 So for example, in these folders, we only saw ICF version 3
Two.
for
Two.
all, sorry 2, for all the 4 patients. There was no ICF version 1 in any of them. So what
So
should-
that means that, you gotta check, okay, were these patients screened
okay.
after the release of
Okay,
version
okay,
2?
yeah.
Because then they don't have to sign version 1.
Okay.
But if they were in the study during version 1
Hmm.
Then they
and
will-
version 2 came out,
Okay.
they have to sign version 2 also.
Okay.
Okay.
So how do we know that if they enroll after version 2?
Because the ICF, once they're approved, they have a date on the
Okay.
bottom. It says
Yes.
approved.
Yes, yes.
Okay, we'll
Got
say
it.
approved by IRB
Mhm.
on October
Oh.
24th.
Okay.
So I know if I have a study and the new ICF is approved today,
Okay.
anyone who's already in my study needs to reconsent.
Yeah.
Anyone who screens from tomorrow,
Yeah.
only the new one. They don't
Okay.
need to have the old one.
Yeah, that was the question in the final exam. I
Yeah,
remember that,
yeah.
yeah.
The final exam, brutal.
It was.
I don't think it's brutal.
No, it was tricky. It was
hard.
tricky.
Wasn't
For
easy.
me, it was tricky.
Yeah?
It was easy, but like it was for 1.5 hour, and I took whole 1.5
Yeah.
hour to finish.
But if you tried, like if you took time to want to learn
Mhm.
during the 3 months, it should not be difficult.
It was not difficult. It
Yeah.
was just tricky. Like
Yeah.
I
Right.
was stuck in between two options, two last
Yeah.
options.
And some of those I made it hard. I was laughing when I made it.
I found few questions, I would not say out of syllabus, but some things you can say like for my common sense or something, so maybe.
I put some answers that I know students make mistakes, and I knew that the trick answer. A few. I picked like 3 like that. Because I want to make it like a little challenging. And then
Yeah.
Chris has some like that too. I hate
Okay.
that.
So
That's
we
why it's a
have-
little bit tricky.
Yeah. So that's a good thing to pass the exam.
That's very good. If somebody took that right now that doesn't know anything about research, there's no way they're gonna pass.
Yes, right.
No way. And if someone took it with only like not even reviewing all the modules, they're not gonna pass. We made it so you have to review the modules and be on the webinars, or at least listen to the webinars
Yes.
to pass. And if you don't do that, then you shouldn't pass.
Right.
Because we don't want people, we don't want people going to interview.
Yeah.
And it's gonna make you look bad too,
Yeah.
because they have the same education on their CV.
Yeah.
Yes.
CRA Academy. We don't want that. We need it. Actually, it should be harder. You guys should hope that it's harder in the future.
Yes.
Yeah, in the future.
That's what she's mean.
Shoot.
Yeah, she's tough.
I'll be nice though. I'll try and be. Like, no, kick him out. What is
Kick
this?
them out. Oh, ICF. Okay, so yes, you're right. So the amendments. Okay. What do you do? Just like this is automatically triggers in your brain to do these things. Okay. Patient is screened. Okay. What does that trigger in your brain? The next thing.
Did they sign as ICF?
Yeah. Okay, but after that, what do you look for?
After signing the ICF?
Related to the ICF, but after signing it. You want to see it.
Exclusion?
Yeah, maybe I'm not asking it clearly. It's a note. The site has to write a note at screening.
Okay.
Okay. They have to write a progress note. They have to write a progress note every visit. But what do they need to include in the screening? In that note.
What subjects?
Related to the ICF.
The patient, all the ICF process.
There you go.
Okay.
Process of consent.
Yeah.
It should be like automatic. Okay, your brain thinks, okay, new ICF,
Okay.
new process, or an amended ICF. Okay,
Okay.
same thing. If it's at visit 5 that they sign a new one, process of consent, you need to be seen.
Like subject was given enough time to understand the ICF.
All that stuff.
All those things.
Given a copy,
Yes.
whatever the site
All
SOP
the-
is on the consent,
Okay.
it needs to be written in there.
Okay.
Some sites are smart about it, and they'll use a template on their source. So ICF amended, and they'll have a checklist.
Yeah.
Like this book is good, Checklist Manifesto.
Oh, really?
Yeah, this talks about how like checklists can prevent errors.
What is it called?
Checklist Manifesto. It's written by a doctor, actually. Same thing, sites can do this in their source when they create source. And you guys just created a source, or you reviewed a source that was been created. Yeah, it's a good book. Atul Gawande.
Book?
Atul Gawande.
Okay.
Okay,
He's like
it's-
one of the doctors for Amazon, I think. No, seriously. Like Amazon hired him to do like health related stuff.
Wow.
Yeah, he's big.
Amazon is in everything.
There. Man.
Yeah.
But checklists, okay? So it doesn't have to be a checklist though. It could be written, okay? Subject came in today, discussed with who? Who did they discuss with?
That was a question I had in my head before coming, and because I know I'm going to forget. How do you develop trackers for your visit? Or do you have like sample templates, to
Excel.
monitor what?
Excel. These are the things you want to track. Training, FDF, license expirations,
Okay,
GCP expiration,
okay,
IATA expiration. All these things expire.
okay.
Okay. Who has signed which? Who has signed what training log? Which version of the protocol? Who signed for that?
So this is what you do. You say, okay, protocol 1245, and then you say site 4567, and then you put like training log.
You put training log, version of protocol trained,
Okay,
and then all the staff.
all the stuff. And then you go to the next one.
Yes.
That way you just have that, and then you can just click worksheet 2, worksheet 3, whatever.
Yeah.
So with the shipment and the facility, would we inspect the facility for those things
Yeah.
before we start the review?
Not before.
But
It could be
sometime
anytime.
during the visit.
So for cancer studies, it's whenever the staff is available to show you that.
Okay.
Sometimes you have to schedule with the pharmacy.
Oh.
At this site, we don't, but at some big ones, you do.
Yeah.
So
especially
the
at
pharmacy
hospitals.
doesn't care what time you're there. They say, hey, come at 2 o'clock. You have to schedule it. So no matter what you're doing,
Mhm.
at 2 o'clock, you better be there because that's the only time they have for you.
Okay.
And then you can come back and finish your other tasks.
Okay.
Okay.
And they're not gonna wait for you. At this place, they'll wait because it's smaller.
Okay.
But like at UCLA or UC San Francisco, they're not gonna wait. You're lucky if they know you're even there. You have to schedule it.
Okay. Do you schedule it before you come for the
Of
visit?
course.
Before you come for the
Yeah.
visit.
Yeah.
So
They're gonna
then
get
you
you
go-
on their calendar.
Okay.
Yeah. It's strict. Like at these big places, it's strict.
Yeah.
And if you're there and you forgot to schedule it, they don't have to let you. And then you have to write in your report why you didn't go.
My fault.
My bad.
Yeah, you don't want to. That's why you want to be nice too.
My bad.
That's why you want to be friendly, because sometimes the coordinator can help you.
Okay.
So I'm a little bit confused about what we did in those days regarding source data verification, because we didn't have EDC.
Okay.
But exactly in SDV we need to verify the transcription, like from source data to ECRF, everything is transcribed correctly. We need to see that in SDV, basically SDV.
That's SDV, yeah.
So
We'll have
Yeah.
access to the EDC.
This study
tomorrow?
does not use EDC.
Okay.
for tomorrow's study.
Yeah, it doesn't use, it's a pilot study, so it's
Okay.
not using EDC.
So
Okay.
It's
this
just
is
source,
okay. So this was the SDR we did today?
SDR.
Okay.
SDV is easy.
Yeah, it is.
SDR is the hard part.
Mhm.
Okay.
SDV,
Mm-hmm.
yeah, there's no, this study doesn't even have a EDC.
Okay.
Then if they like the results, they will do a big study and then they have to have EDC, because this is not a FDA study.
Okay.
This is
Oh.
just for the company to see if it's worth it doing an FDA study, but we're treating it like an FDA study. We have
Okay.
1572, we have everything like for good practice for them,
Mhm.
but it's not really a
An
FDA. They're not sending this data to
Mhm.
the FDA.
Okay.
They're using it to see, okay, we're at these two, in this small 20 patients,
Mhm.
is it worth doing a bigger study? And I think it
That's
is.
good,
I
yes.
think it is. The only question now is, can we get the patient? Because from what I hear, the drug is like really good.
Okay.
So if we do a good job, we get the big project.
On
I
this
think
one.
it's a matter
Well,
of
it's,
impressing
you know,
the doctor.
I saw a lot of subjects that were reporting adverse effect though.
Oh, no, I'm not talking about this study.
We're talking about the,
I wish I had that study. I would
But
be
this one-
multi-millionaire.
this one they were talking about,
Yeah, this is a
People-
huge, like, big sponsor. And the CRO is huge. This was like a 100-site study.
Oh, wow.
Oh yeah, this is like a 9-figure budget for the CRO. This one.
When you say for the CRO, for all CROs.
No, remember, every study, only one CRO.
Okay, yeah, only one CRO, that's it.
Or none.
Okay, one CRO.
Or none.
Yeah.
the
Sometimes
sponsor
it could
can
just be
do
the
it themselves.
pharmaceutical.
Yeah. 100 sites. I think this study was like 100 sites.
So now the CRO will now look for
I wouldn't even be capable of doing this for my CRO. I don't have that kind of
capacity.
infrastructure. I can do these kind of small studies.
Okay.
That's what you start out with. But these are like basically 6-figure budgets. Small. That's like an 8-figure, maybe 9. And that's completely different. But like they have multiple CRAs. Because in 100 sites, one CRA will maybe have like 4 sites.
Mhm.
And it's a lot. And then so you have like a team
Wow.
lead, in-house CRA. These are all jobs you can apply for too. In-house CRA.
In-house CRA, you have to be,
In-house?
well, yes, literally.
Literally, but not in your house though.
Yeah.
To make it even more confusing. You're
That's true.
in-house,
Well,
you're not in
in
your
office. In office, you should be saying.
it should be in
not
office.
traveling.
Because a regular CRA is a home-based
Okay,
CRA.
that's the differentiation.
Usually,
Okay,
sometimes they're in-house, but not in-house CRAs.
okay,
But they're in-house in the company. Or you could be home-based.
okay.
But no, you're not an in-house CRA if you're home-based.
Like,
So
in-house
that's
very
is-
confusing.
think
Okay,
of it like,
that explains the question I asked you one time before. So hospital-based CRAs are probably in-house CRA.
Correct.
so if you think of a
But they're
9 to
not
5,
in-house CRA.
Not in their house, but in the
But also
hospital.
not
Yeah.
traditionally what the in-house title is. Because
Okay,
they're CRAs.
yeah,
In-house CRAs deal with paperwork, not with sites so much.
but it could
Or with
possibly be,
SDR.
for example, like we have Piedmont Hospital. We have Piedmont Hospital Heart Center, for example, and they do have like cardiovascular studies.
Yeah.
And I'm sure, well, I don't know. It's
So here's it,
some
okay.
presumption. It's quite possible they may have some studies in Piedmont and in other hospital locations.
Yeah.
that's affiliated with Piedmont.
That's probably
Yeah.
affiliated with Piedmont.
Check this out. One of these will write. So this you have like the, let's do a regular study first. Okay, you have the sponsor,
Okay.
okay, CRO, and then sites. And you have like a lot of sites, okay? So, the sponsor doesn't employ any CRAs in this case. So the CRO does, okay? So the CRO has one CRA that goes to these 3 sites,
Okay.
okay? This is a home-based CRA. She works from home,
Okay.
okay? Also, the CRO has an in-house CRA that goes to the company office every day and assists with scanning everything this CRA collects. Everything this home-based CRA collects when she's on site goes to this in-house CRA who's in the office to upload everything in a trial master file.
Trial master file.
They're the ones that keep this tracker. And then they tell the CRA, hey, this site is missing this, this, and this for these guys. Okay? So now this CRA knows what to put on their action items. Or knows what to look for. And then they get it back to them. So that's the in-house CRA's function. They don't do SDV, SDR.
They do.
No. They help with
Okay.
these kind of things. Okay, 1572 needs to be changed at this site. That's what they track. And now at a university, the university can be the sponsor and the site at the same time.
Okay.
Alright, because they do a lot of the study we're monitoring,
Mhm.
they do a lot of those kind of studies. Pilot study. So there is no CRO. It's them as the sponsor, CRO, and the site. They have different departments. Alright, so in their case, the CRAs work in the office, or they could be home-based. But it makes more sense to work in the office because the office is the site.
Okay.
And then they could have in-house CRAs that do all these functions I mentioned
Okay.
as well. That's very confusing.
What
So
do you
they-
see as more like, I guess, attractive to job seekers, in-house or regular CRA?
Well, regular CRAs, I don't want to say better because everybody's different, but it's more, generally more desirable because the pay is better.
Because you have to travel.
Yes. You have to, these people travel, these people don't.
Yeah.
They're still called a CRA though. And this is usually a stepping stone to being a CRA.
Oh, okay.
And what about the when some study is going on in the hospital?
Same thing as this.
Okay.
University / hospital.
So the CRA there will pretty much, will
Stay
still
on
be
site.
looking
Remember,
at-
they're doing like thousands of studies.
Yes, they are.
Like Emory, okay,
Yeah.
like the study we're monitoring tomorrow, they would have like 600 of those studies.
They have a lot of studies.
So they have all their CRAs work
So
there.
you think they
their
have more
coordinators work
CRC
there.
than CRA probably?
Yeah. Yeah.
Mm-hmm.
Because remember, they will be employing the CRCs too.
Mm.
In this model, the sites employ their own CRCs. In this model, the site is the university. And so the CRCs also work for everyone works for the university.
So the CRA in that one will be just looking at each protocol. Will be
Whatever they're assigned to.
whatever they are assigned to, the monitoring,
Yeah.
the different
And they
protocols.
only have one site, or like you said, if they have another location that's doing the same study,
Mm-hmm.
because
Could be in the
enrollment,
same, within the same geographical location.
and why would they have another site? Because enrollment is never what they say it's gonna be.
Yeah.
So then they need more sites.
Yeah.
Nobody wants to add more sites because it's fun. I mean, it's more resources,
Wasted.
where else are you gonna get patients? If this site lowered its expectations in the middle of the study, you have to get another site. So that's what makes it confusing. That's
Okay.
this is the traditional industry model. Separate companies, separate companies, separate companies. This is like academic research of the same company. And in addition to their 600 studies they're doing, the university,
Okay.
they also can get these kind of studies too.
Oh, yeah.
So then they have separate departments for that. They have departments for industry-sponsored trials and in-house trials. Alright, or the same coordinator can work on 2 different kind of studies. And same with the CRA. In that case, the CRA won't monitor these studies because the sponsor will have their own CRO.
Okay.
It's confusing.
I'm still confused about note to file. What exactly
Oh.
it is? I tried to,
Those are very good, but they could be abused as well. But I think they're very good. I think they're underutilized,
okay.
note to file, and other CRAs think that they're abused. I, in my experience, have not seen that they're abused. I've seen that they're underutilized by the sites. So it's good to explain anything. It's basically an extra form of documentation,
Okay.
alright?
Okay.
If you need, like something happens unscheduled, okay, it's an unscheduled visit, or if you made a phone call to the patient because they report a AE, or
Yes.
you made a phone call to remind them of their next visit,
Okay.
and they say, okay, that's fine, I'll be there, that doesn't require a note to file. But if you call to remind the patient of their next visit, and they tell you, okay, I'll be there, by the way, I had a bad stomachache
Okay.
yesterday, now you gotta pull out a note to file
Okay.
and document.
I get it.
But some CRAs don't like it because some sites abuse it by, I guess, avoiding obtaining documentation, like let's say a diagnosis. If a study, like a schizophrenia study, requires a diagnosis, okay, and the site can't get the diagnosis, they'll write a note to file.
Okay.
Subject has schizophrenia
Okay.
as per his psychiatrist, who we spoke to on the phone on this date. Okay. And they write that down. That's okay, it's Alcoa, GCP, but the sponsor or the CRA prefers they get the actual diagnosis.
Right.
And so they say that that's an abuse.
Okay.
I say it's better than not having anything.
Yeah.
It depends, there's different schools of thought, but that's no fun. Because then the argument is, well, it's much easier to do this than to try to obtain the medical records. So that's where the sites could abuse it. They just stop asking the other doctor for the diagnosis and just do a note to file.
Okay.
Okay.
I've done it though, as a site, I've called doctor and asked, hey, this patient, I'm calling from the site, I've been faxing you medical records request, I'm not getting anything back. And then they'll have to check that they got the form.
Okay.
And then I say, hey, instead of like, can you fax it back to me? And they say yes, but they don't do it. Next time I call, now they know me. And I say, hey, send it, but can you confirm this? And then I write it down. Okay, so now I have, and they still don't send it to me, but I have it written.
Okay.
So now my patient, I have everything I need. The next time I get a patient from there, I know that they're not gonna send me anything.
Okay.
So instead of even trying, I do this again.
Okay.
And that's where they say it's abuse.
Right.
But at Note to File, I love it. I actually don't see enough people using it. People
That's
don't
a
use
good
it.
thing.
As when you're deviating from the protocol, alright, sometimes it's unavoidable. You should always put why you did it. Alright, sometimes the site does it for a valid reason, like safety concern,
Okay.
but they don't document anything. And so then to an auditor it looks like they don't understand why that happened. You know, with a Note to File, you cover yourself. It's still a deviation, but there's rationale
Yeah.
why you did
Right.
it. That's why I like them. They explain things and it makes it more clear for your monitor to see what's going on.
Yeah.
But there is those people that say it's abuse.
But it's a good thing to have Note to File if you are
I think
missing
it's better than
something.
not.
Yeah.
I'd rather be on that side of having it than not having it.
Yes.